Hello, my name is Dr. Matthew Ward, and I am a radiation oncologist here at the Levine Cancer Institute. I have been practicing in Charlotte as part of Southeast Radiation Oncology Group since 2017 after completing my residency at the Cleveland Clinic. I have a practice focused in prostate cancer, and I look forward to meeting you at your upcoming visit. I have found that there is a lot of information to discuss during a consult and many questions naturally arise. I wanted to share this video with you so you can begin to understand more about your diagnosis, treatment options, and some details on radiation. Please watch the video in its entirety prior to the consult. When we are together, I will be able to provide you with some specific recommendations based upon the details of your case. Please be aware that many men will have multiple very good treatment options available, including both surgery and radiation. We will consider all options at your upcoming visit. Understanding some of these basics before the visit will hopefully allow us to get the most out of our time together and make sure all of your questions are answered. It will also provide you a resource you can look back at if new questions come up later. Before we talk about treatment options, I wanted to give you a little background information. The prostate is a small organ about the size and shape of a walnut. It lives just under the bladder, surrounds the urethra, and in front of the rectum. Prostate cancer is the most common site of cancer in men. In the United States, there were around 300,000 cases diagnosed last year. The good news is that treatment is successful for most patients. Because the chances of controlling the cancer are often quite high, decisions about the best possible management are often nuanced and center on when do we treat and how aggressive should we be. In order for treatment to be truly successful, we need to make sure you have the best possible chances of both controlling the cancer and preserving your current quality of life. It is important, however, to understand that not all prostate cancers are created equally. Some are extremely slow-growing and others require immediate attention. To help us to understand more about your prognosis, we complete what we call staging. For most types of cancers, you may have heard this referred to as stage 1 through 4. For prostate cancer, we approach it a bit differently. We have created what we call risk groups. In order to determine your risk group, we take into account the extent of the cancer in the prostate from exam and any imaging you have had, which is what we call the T stage, the grade group or Gleason score of your cancer, which is how aggressive it looks under the microscope, and your PSA level. The risk groups include low risk, favorable intermediate risk, unfavorable intermediate risk, high risk, very high risk, node positive, and metastatic. And when I talk about risk, what I mean is the risk your prostate cancer can return or spread after treatment. The word for this is metastasis. Your risk group determines which treatment options are most appropriate. I would encourage you to spend a couple of minutes reviewing this table. It should provide you with a little sense for how risk groups can alter some recommendations and when more scans may be helpful. For men with cancer confined to the prostate or limited to the areas just beside the prostate, the goal for treatment is to eradicate it completely and prevent it from spreading or metastasizing. For some men, typically those in the low-risk group, active surveillance is often preferred. For low-risk cancer, the risk of spread within a 10-year period is about 1 to 2%, and there is a good amount of evidence that men with small amounts of slow-growing prostate cancer can be safely monitored for signs of growth before needing to pursue definitive treatment. Importantly, doing so does not compromise the prognosis. If you fall into this risk group, we will discuss this more in depth during your visit. If you have intermediate risk prostate cancer or higher, upfront treatment will be preferred in most cases. Most men will have options for both surgical removal of the prostate, known as prostatectomy, or radiation. National guidelines based upon best available evidence support both as preferred options. The reason is that the long-term prognosis is the same between both of these strategies. The largest randomized trial ever conducted that compared surgery and radiation head-to-head is known as the Protect trial. It included over 1,600 men with organ-confined prostate and showed that 15 years after treatment, the odds of being alive and cancer-free were the same for both treatments. There are often good reasons to prefer one treatment over the other based upon many different factors. Other times, it may simply come down to personal preference. During your visit, we will definitely talk through some of the advantages and disadvantages of both treatments. When I talk about radiation, what I mean is X-rays. These are high-energy X-rays that kill cancer cells. So the prostate remains in place, but you can focus or target the radiation on the gland. It comes in two forms: external beam radiation or internal radiation, which is what we call brachytherapy. Let's first cover external beam radiation. This is where the radiation is given from the outside in using a machine called a linear accelerator. The most common form of external beam radiation is what we call IMRT, which stands for Intensity Modulated Radiation Therapy. This is the term that describes how we shape and sculpt the radiation dose to make it as conformal as possible just on the prostate. IMRT is a process and not an event. Radiation is most safe and effective when you give it in a series of smaller treatments. In this case, the treatments are daily, Monday through Friday, for a period of weeks. There are different schedules depending on the situation. Some treatment courses can be completed in 4 weeks, others will require 8.5 weeks. Each treatment is just a short visit lasting only 10 to 20 minutes and is most like having an X-ray appointment. You lie on a table, still and flat. The machine moves around you. You don't see it or feel it. However you feel when you come in for treatment is how you will feel when you leave. No one will know you are taking treatments unless you tell them. You won't look sick or feel sick. There are no restrictions while you take radiation. You are free to continue working or participating in your usual activities. You just have to carve out the time to receive the treatment each day. The process begins with radiation treatment planning, which is what we call a CT simulation. Radiation is not one size fits all. It is designed custom for you. Everyone's anatomy is unique and the prostate is a different size and shape. Radiation is most precise and accurate when the treatment is reproducible. We make some custom molds for your legs so that we can position you the same way every day. Treatment typically begins 1 to 2 weeks after this visit and will continue daily. Any side effects you may experience from treatment are gradual and limited to the area where we are treating. Side effects could impact urinary, bowel, or sexual function. Changes in bathroom habits are common during treatment and can result from inflammation and swelling of the prostate, urethra, bladder, or rectum. The most common side effects are increased urinary frequency or urgency to pee, and maybe a weak stream when you pee, or trouble emptying your bladder, getting up more at night to pee, or sometimes burning or stinging when you pee. Some people have increased frequency of bowel movements or loose stool. About half of men will characterize their side effects as mild, which I define as changes you notice that don't require any medicine to help. The other half of men will have moderate side effects, which means they may benefit from medicine until things improve. Almost always, the side effects of radiation are temporary, meaning they will improve within 2 to 6 weeks of treatment. Maybe 1 in 4 patients will require 2 to 3 months to get back to normal. Only rarely are these chronic, lasting longer than 6 months. The risk of chronic side effects from IMRT is about 5 to 7% and could include chronic inflammation of the bladder or rectum. The risk for serious side effects, which I would define as requiring a procedure to fix something, is very low. People are often concerned about radiation causing a new cancer, meaning you are cured from prostate cancer but develop a new cancer such as bladder or rectal cancer. This can happen but is very rare and would be 5, 10, 15 or more years in the future. The risk for a new cancer caused by radiation is about 1 in 400 within a decade of treatment. As I mentioned already, there are different treatment schedules and durations of treatment. In order to get done faster, you can deliver a little more radiation each day, meaning a shorter schedule is not less effective than a longer schedule. The best way to understand it is thinking about the difference between 4 quarters and 10 dimes. Either way, you get a dollar's worth. You may have come across the term SBRT, which refers to what we call stereotactic radiation. One brand name for this is called CyberKnife. This refers to a way to deliver almost a week's worth of radiation in single treatment, which allows you to complete prostate treatment in only 5 treatments, typically spread out over 2 weeks. This provides a significant convenience for people who are interested in external beam radiation. Not everyone is a candidate and the side effect profile is slightly different, but best available evidence indicates that the treatment is just as effective when offered to the right patients. The other option is internal radiation, what we call brachytherapy. Instead of using a linear accelerator to give radiation from the outside, you use a small radiation source to deliver the radiation from the inside out. Brachytherapy is more of an event than a process. It's a minor procedure that is done under anesthesia. There are two major types of brachytherapy: LDR, which stands for low dose rate, and HDR, which stands for high dose rate. The difference between the two is what type of radiation source do we use, one that gives radiation very slowly over months, or one that gives the radiation very quickly over minutes. Let's first go over LDR brachytherapy. This is more commonly known as prostate seed implant. We call them seeds, but they are really capsules made of titanium. They are hollow on the inside and contain tiny amounts of radioactive material. Most commonly, it is iodine-125, which has a half-life of 60 days. The seed is permanent. Once we put it in, it stays forever, but the radiation is temporary. It gives off the radiation slowly over a period of months and eventually dwindles completely away. So the idea is, if we place the radiation directly on the inside, that is the best way to keep the radiation contained within the prostate to help keep it away from the bladder and rectum. Also, you take it home with you so you don't have to come back and forth for daily treatment. However, you are radioactive when you go home, so that comes with some minor restrictions. Mainly, no holding babies and no children on the lap for 3 months after the treatment. Also, you would need to stay 6 feet away from anyone who's pregnant. Let's review how the procedure is done. Once you go to sleep, we can place your legs up and use an ultrasound in the rectum to visualize the prostate, similar to how your biopsy was done. I then place needles very precisely into the prostate with ultrasound guidance. When your biopsy was done, the needles probably went through your rectum. These needles go through the skin in the area just in front of the rectum. Once the needles are in, I strategically place each seed spaced out through the prostate to cover the gland and minimize radiation to the urethra. The procedure takes about an hour and a half, but you would be here for about half the day after anesthesia recovery. We do place a catheter in your bladder that would stay in place for 24 hours to reduce the chance you would have any difficulty emptying your bladder. For HDR brachytherapy, the procedure from your perspective is very similar. It requires anesthesia, rectal ultrasound, and strategic needles inside the prostate. The key difference is that once the needles are placed, instead of depositing a radioactive seed, I connect the needles via catheter to a robot called a remote afterloader. This machine contains a single, very fast-acting radiation source, iridium-192, which we can send inside the prostate for just a few minutes, then remove it so nothing is left inside of you permanently, and you would not be radioactive when you go home. Because the radiation is given more quickly, we cannot give as much radiation as we need to in a single treatment. So for HDR brachytherapy, 2 treatments are required, which are typically spaced 1 to 2 weeks apart. If you are a candidate and interested, we can discuss further specifics and aftercare when we are together. We can also compare and contrast LDR and HDR a little further. It is worth mentioning that some patients with higher risk prostate cancer may benefit from what we call combined modality treatment, meaning half the radiation is given external and half is given internal. This strategy increases the total dose in a safe manner and is effective against higher risk cancers. When comparing brachytherapy with external beam, a list of potential side effects is essentially the same, but the way patients experience it can be different. It is important to point out that the acute side effects of brachytherapy, meaning the degree or urinary tract aggravation that you would experience immediately after treatment, are more prominent than with external beam radiation. Instead of being non-invasive, you are poking the prostate with some needles, which contributes to more swelling. However, because the radiation is better contained within the prostate, the risk for chronic inflammation of the bladder and rectum is a little lower with brachytherapy. The risk is typically in the range of 1 to 3%. Some patients can be considered for proton therapy, which is a form of radiation that has existed for a number of decades, but received a lot of attention recently as more centers are built. We are fortunate to have this option available at Levine Cancer Institute. Protons have both charge and mass, so they interact with tissue a little differently and provide some benefits in lowering side effects for certain patient populations. What I would like you to be aware of is that the best available evidence indicates that proton therapy does not improve quality of life when compared with more traditional, modern forms of radiation therapy in the routine treatment of prostate cancer. It may still be beneficial in certain circumstances, but most men will not benefit from this form of treatment. If this is something you are curious about, I would be glad to discuss this with you in more depth during our visit. I would also like you to be aware that some men who receive radiation will benefit from the addition of hormone therapy. Hormone therapy refers to a medicine, either a pill or injection, given to lower your testosterone level. Testosterone can stimulate prostate cancer to grow, and it is sometimes necessary to lower this level to get the best possible result. Men who benefit from the addition of hormone therapy are those with high-risk prostate cancers and select patients with intermediate-risk prostate cancer. When given to the right patients, the combination of hormone therapy and radiation therapy can significantly increase your chances of remaining cancer-free after treatment by reducing the chance of cancer spread. If recommended, hormone therapy is typically given for at least 6 months and up to 2 years in some cases. It would be started before radiation therapy begins and continue after radiation is complete. You should be aware that it can be accompanied by some unwanted side effects, which are most similar to the symptoms of menopause experienced by women. Common side effects include hot flashes, mood swings, weight gain, decreased libido, and decline in muscle mass. These side effects are temporary and reversible once hormone therapy is completed. When planning radiation, I put considerable effort into making sure the risk of side effects is as low as possible. As I mentioned previously, there is some risk of inflammation to the rectum from radiation that can lead to changes in bowel habits. It is possible to place what is known as a rectal spacer between the prostate and rectum during a course of radiation to reduce the chances of developing bowel side effects. This requires an elective procedure to inject a hydrogel in the small space between the prostate and the rectum. This creates a separation between the prostate and rectum that moves the rectum away from the zone of high-dose radiation, which has been shown to reduce the chances of unwanted bowel symptoms. This hydrogel is a material commonly used in cosmetic and other medical procedures as a filler. It is broken down and dissolved on its own over a period of months, what we call bioabsorbable, but remains in place during the treatment to serve this purpose. This is not advised or appropriate for all patients, but I wanted you to be aware that this may be an option to consider. Benign swelling or enlargement of the prostate is common in men over the age of 60. This is known as BPH. Most men above the age of 60 have some degree of BPH. This can create trouble urinating that is entirely unrelated to the cancer itself and may have been happening for many years or even decades prior to your diagnosis. Men who have good urinary function before treatment are the ones with the fewest side effects during and after radiation. So commonly, I will recommend some simple testing to make sure you empty your bladder well before we decide on treatment. For men who have difficulty with this problem, addressing it in some way, either medically or surgically, before treatment can set you up for the best possible outcome and lowest possible risk of side effects. Surgical treatments for BPH may include a TURP or transurethral resection of the prostate, a HOLEP, a PAE, or other procedures performed by your urologist. It may be worth your time to think about these procedures before we meet, particularly if you feel you are already having difficulty emptying. If you choose surgery, it is important to know that radiation therapy may be necessary after. Maybe 10 to 20% of patients with early prostate cancer may have their PSA rise at some point in the future, at which time we begin to entertain salvage radiation. For higher risk cancers, this chance of the PSA rising may be 40 to 60% or even higher depending on how advanced the cancer is. Typically, radiation after surgery lasts about 7 weeks. Sometimes we will add hormone therapy as well. The comments above about radiation logistics and side effects apply to the post-surgery situation as well. It is often said that if you have surgery first, you can still have radiation, but if you have radiation first, you can't have surgery. This is because scar tissue around the prostate after radiation makes it difficult to heal from surgery. However, it is important to know that the chance of having cancer regrow in the area the radiation is delivered is very low, approximately 2 to 3% at 10 years. After radiation, any cancer that is detected is usually somewhere else, either in a pelvic lymph node or a bone. Unfortunately, this can happen at similar rates after surgery as well. This is why the best available evidence suggests that the chance of developing metastatic prostate cancer is about the same whether you start with surgery or start with radiation. If you were to end up in the small number of patients that do develop a recurrence in the prostate after radiation, then there are other options such as hormone therapy, cryotherapy, HIFU, or rarely reirradiation. Often we are asked, what can I do to help? While there are some things in this life that are beyond our control, we do think maintaining a healthy lifestyle helps in many different ways. We do recommend continued exercise throughout treatment. Both cardio and strength training are important. For those taking hormone therapy, this is important to minimize weight gain, maintain muscle, and reduce any risk of osteoporosis. There is no specific radiation diet, but we would say many of the same things your cardiologist would say. A heart-healthy diet full of natural foods, low in saturated fats, simple sugars, and ultra-processed foods seems to be optimal. If you typically consume alcohol, there does not seem to be any serious interactions between small amounts of alcohol and radiation therapy. Here at Levine Cancer, we are fortunate to have a Department of Supportive Oncology, and if you would like to discuss complementary medicine in depth, we are happy to place a referral. Well, that concludes the video. Thank you for watching. I hope you found it helpful. Now that you understand the basics, I hope that we can use our time to explore the nuances of your personal goals and wishes when we meet. I look forward to meeting you, and I wish you the best on your journey.